Great, thank you. Have a good day, everyone.
You too.
Thank you, you too.
All right. How's everyone doing today?
Thanks for asking.
Excellent. So I believe last time we went through kind of an overview and we did some mostly kind of squamous oral epithelial mucosal based lesions. So we're going to move on today to other compartments of the head and neck. So does anybody have any questions or comments or feedback based on last session? No, okay. All right, so correct me if I'm wrong, but we have not done any of the sinus yet, correct? For this?
No, we didn't. We did not.
Okay, cool, thank you. All right, so we're gonna start, there's a lot of diseases that could happen in the sinuses, anywhere from sort of reactive inflammatory, benign tumors, malignant tumors. So we're gonna spend a bit of time on the sinus. So normal kind of sinonasal respiratory type mucosa, once you make the transition, from the skin kind of squamous to the outer nose, you transition to this respiratory type pretty much most of the way back. And this is pseudostratified ciliated columnar epithelium. Pseudostratified because in fact, when we examine these cells in the surface, every single one of them actually sends a piece of cytoplasm to touch the basement membrane. So every single cell touches the basement membrane. If it's truly stratified, then the cells at the top don't touch the basement membrane. So that's where the pseudo comes from. Certainly ciliated, and there's certainly these stromal mucosal glands that secrete mucin and enzymes, et cetera, to lubricate the airways. Because this is an antigen-rich area, of course, there's always some inflammatory cells in the stroma to manage the potential allergens and inflammatory response. So what we see in the sinuses most frequently is certainly just sinusitis, and sinusitis could take many forms, from inflammation to fungus, et cetera. And so sometimes what is present just floating in the sinonasal cavity are these mycotomas or fungus balls. And so these are usually balls of aspergillus that may or may not have an actual inflammatory reaction around them. But what we generally see is essentially just hyphae like this with septations, with branching, and all of this purple is just the ball of the fungus. This doesn't have any invasion into the tissue. Sometimes these fungal balls are associated with actual inflammation, fungal sinusitis. Sometimes the inflammation, the fungal sinusitis, is not associated with these balls, right? So it can come in any hybrid of combinations. So allergic fungal sinusitis is an allergic eosinophil-rich reaction to inhaled antigens and fungi, spores, yeast, whatever in the air. And so again, the fungus isn't necessarily present in the tissue because that's a completely different story, right? But here we have a rich inflammatory response in the stroma that's full of eosinophils. These patients end up actually secreting a lot of mucin into the airways. And so we see this pink extracellular mucin that's floating around in the air spaces with pink eosinophils in the mucin, with these so-called Charcot-Leyden crystals, which are basically the degranulated products of the eosinophils that are sort of clumped or clustered together. Sometimes if you apply a GMS, a silver stain onto the mucin, you can see that the fungus actually highlights in black. And so this is, again, an extracellular process that's kind of, again, floating around in the sinus. And this is called allergic mucin. And sometimes you see it in response to allergic sinusitis in the tissue. So one of the end stage manifestations of sinusitis are these so-called inflammatory polyps. And so they are basically redundant, exuberant polypoid inflammatory response to inflammation. You can see they have a thickened basement membrane. You can see, again, they have lots of eosinophils in the stroma They have cystically dilated glands. They could appear as masses, but in fact, upon histologic examination, they're just, as I said, exuberant inflammatory responses. So these are sinonasal inflammatory polyps. Another possible manifestation of chronic sinusitis is the so-called respiratory epithelial adenomatoid hamartoma. Again, this is not a neoplasm, but these appear as mass-like lesions, usually hanging from the bilateral olfactory clefts of adult males. And these are thought to be hamartomatous, meaning they are abnormal proliferations of epithelial glandular units normally found in this location. So you can see here, there's quite a exuberant proliferation of these respiratory glands, forming these sort of small donuts in these almost like elongated hot dog shapes. They again have thickened basement membranes around the epithelium, and they sometimes have small acinar proliferations as well. So this is a characteristic kind of clinical pathologic correlation of these adult men with these olfactory cleft lesions, and we see these histologic pictures. Again, this is a benign, non-neoplastic hamartomatous process. In the counterpart of invasive fungal sinusitis, as you know, this is more of an immunocompromised state, right? So these people usually have histories of lymphoma, leukemia, that have stem cell transplants, et cetera, are severely immunocompromised. And in this case, because they don't exhibit a very robust granulocyte response from neutrophils, eosinophils, et cetera, they actually manifest tissue invasion by fungi, right? And so the fungus start to invade the tissue. They start to invade the blood vessel wall, which is what we see here on the left. And they start to form thrombosis in the lumen of the vessel. They therefore cause tissue necrosis, which is what we see in the middle. And if you apply a GMS stain again to the tissue, you may see actual fungal hyphae in the tissue. So this is angioinvasive, necrotic, invasive fungal sinusitis, usually mucor, sometimes aspergillus, in immunocompromised people. Other necrotic midline nasal diseases that we may see include Wegener's, formerly known as Wegener's, now granulomatosis with polyangiitis, which, as you know, is an ANCA-associated vasculitis. So the histologic triad that you see in Wegener's are going to be granulomas, which are these collections of epithelioid histiocytes, are going to be vasculitis, which is inflammatory cells within the wall of the vessel, and then these small clusters of neutrophils or neutrophilic microabscesses. Sometimes you do not see, or sometimes we as pathologists do not see all three histologic features. In conjunction, it's quite specific, but if we start to see one of these three, we may, recommend doing serologic studies for ANCA, et cetera, to determine if there's potentially a Wegener's going on. Moving into the actual sinonasal neoplasms. So one of the neoplasms that we see most frequently is going to be our sinonasal or so-called Schneiderian papilloma. So this has a number of historic names, including sinonasal papilloma, Schneiderian papilloma, inverted papilloma. Essentially, it's all the same picture. Currently preferred terminology is sinonasal papilloma. This is a benign tumor that happens most frequently on the lateral nasal walls. It demonstrates very thickened epithelium with an inverted or nested growth pattern, as you can see here, with clusters of small neutrophilic clusters in the epithelium. So again, these little neutrophilic microabscesses. It's said about 20% of cases, but that may be a little high, transform to carcinoma. The variant of sinonasal papilloma that we sometimes see morphologically is an oncocytic variant. It's otherwise very similar to the inverted papilloma, with the exception of the epithelium has a few more cells that are eosinophilic, very pink in appearance, or so-called oncocytic. Again, to remind us, oncocytes are these large cells with granular eosinophilic cytoplasm, granular because they're full of mitochondria. They are very metabolically active, so they have large nuclei with prominent nucleoli. This is sort of a metaplastic change in a number of organs, but this is, when you hear the word oncocytic, it just means this histologic morphology of these pink cells. Okay, so those are sinonasal papillomas. I can mention that there is also, which I didn't yet, there's an exophytic type of papilloma that occurs more on the nasal septum. Those are easier to excise, therefore result in less transformation to carcinoma. Okay. What we see sometimes in kids, specifically adolescent males, regarding sinonasal tumors is nasopharyngeal angiofibroma. As its name suggests, angio related to blood vessels, fibroma, fibroblasts. So what you can see here are these slit-like blood vessels surrounded by this very, very eosinophilic fibroblastic stroma with lots and lots of pink wavy collagen. These tend, because they're so vascular, right, they tend to be very bloody, very hemorrhagic. These kids present with nosebleeds, and sometimes, they are embolized, of course, before these kids go to surgery to help minimize bleeding. They do express androgen receptor and beta-catenin in the nucleus, so these can be used as markers for us as pathologists. But these are benign. It's mostly just a bleeding manifestation clinically. Okay, moving into the malignancies of the sinuses. So whereas in the skin and squamous mucosal membranes, we are mostly dealing with squamous cell carcinomas. In the sinonasal cavity, that is a very gland-rich area, we're dealing with mostly adeno or glandular carcinomas. So there are two sort of types of sinonasal primary adenocarcinomas called intestinal type and non-intestinal type adenocarcinoma. The intestinal type essentially resembles colon cancer. So it has these large glands with elongated nuclei, this grungy material. It stains like colon cancer, CK20, CDX2, but is related to patients having these occupational exposures to wood and leather dusts. And so if the patient has this type of morphology, has the exposure, but does not have colon cancer, then you could essentially make this diagnosis. The non-intestinal type is a little more morphologically nondescript, sort of more bland, cribiforming. It has the opposite immunoprofile with cytokeratin 7 being positive. CDX2 and CK20, your markers of colonic differentiation, are negative. And so here's an example on increased magnification of what the non-intestinal type carcinoma looks like. Again, kind of nondescript cribiform structures with round to oval nuclei compared to the intestinal type adenocarcinoma, much more complex branching glands with dark elongated nuclei with this very grungy necrotic material in the center of the glands. The intestinal types that appear colonic tend to have somewhat worse prognoses and are considered high grade. What I will also tell you is on your differential between sorry, my PowerPoint is stalling. On your differential between some of the non-intestinal type adenocarcinomas might actually be in the sinuses a salivary gland type carcinoma. So I'm not going to talk about the salivary gland type carcinomas in this context. I will just make us remember that in any area where there are serous seromucinous glands, all the way from the sinus cavities, all the way down the trachea to the tracheobronchial tree, you can get salivary gland type carcinomas. We're going to talk about salivary gland type carcinomas in the salivary lecture, so just be mindful of that. Okay, so moving on to the other high-grade blue cell tumors that are somewhat more specific to the sinuses. These often require a panel of immunostains in order to determine what they actually are, because the H&E morphology, as you can see, is very overlapping, and there's not a lot of histologic differentiating features between these. So here's a table of some of the immunoprofile panel that we look for, including just a broad spectrum keratin to determine if it's potentially a carcinoma. If it's keratin negative, it would not fall necessarily in the carcinoma spectrum. It might fall in a sarcoma or a melanoma type of tumor, or even a neuroblastoma. When we're dealing with the various types of carcinomas, they have some markers and some genetics that might differentiate them. So for example, if you're in the nasopharynx and you're dealing with something that has squamoid differentiation, you might be dealing with the nasopharyngeal carcinoma that's expressing of Epstein-Barr virus. If you're dealing with a so-called INI1 deficient sinonasal carcinoma that's defined by loss of INI1 or SMARCB1 gene. We have nut midline carcinoma, which involves translocation with nut gene. We have sinonasal undifferentiated carcinoma, which used to be sort of a wastebasket of, I can't really tell what carcinoma this is in the sinus. It's staining with keratin and nothing else. It's SNUC, but now we know that these sometimes also harbor IDH2 mutations, so they may have a specific genetic profile as well. When you are something keratin negative and you look like you may have neuropil or rosettes, you may be dealing with an olfactory neuroblastoma coming from the olfactory area. If you're dealing with something that is a small round blue cell tumor that has CD99 and FLY1 and EWSR gene rearrangement, you may be dealing with a Ewing sarcoma. We know these can also occur in the sinuses, even though they're more common in the soft tissues or bones. Certainly you can get sinonasal melanomas arising from the sinonasal epithelium that subsequently invade and form mass-like lesions. So in summary, those tumors we saw on the prior slide ended up being a sinonasal undifferentiated carcinoma, a nut midline carcinoma, an olfactory neuroblastoma, a melanoma. You can actually see some melanin pigment surrounding the melanoma, and in fact, a Ewing sarcoma on the bottom left. So just how immunohistochemistry and genetics are very helpful when dealing with these tumors. I will say an additional word on nut carcinoma because it's pretty rare, but very aggressive. It can happen anywhere in the body. It used to be called nut midline because it was thought to only occur in the midline, like head and neck, mediastinum. But now it's thought to potentially arise anywhere, even though the most common site of origin is still the midline of the head and neck and the mediastinum. This can occur in people of all ages, young adults to older adults. It's essentially a very high-grade carcinoma with primitive morphology, with sometimes evidence of squamous differentiation, and defined by rearrangement of the nut gene, usually with BRD4 or BRD3 as its partners. Here's immunohistochemistry for nut. Here's a fish showing the nut rearrangement. Most of these patients don't survive very long, but their highest chance of survival is going to be entering into clinical trials for targeted therapy against these rearrangements. Okay, any other questions on the jaws, on the sinuses before we move into the next compartment, which is going to be the jaws? Okay. So we'll go a little bit over normal bone histology. We'll talk about some benign things we see in the jaws. We'll talk about some endonogenic lesions and then osteosarcoma as our sort of mesenchymal neoplasm. So normal bone and cartilage appear as follows. So bone is an eosinophilic lamellated matrix when it is mature. You can see these lamellae here. There are very small osteocytes in the lacunae of the bone. And there are osteoblasts that rim the edges of the bone as a feature of benignity and sort of constant bony remodeling. You get bone resorption by osteoclasts. You get bone deposition by osteoblasts. Bone is a constant living, changing organism. Or I should say part of our organism. Cartilage, on the other hand, tends to have a more homogeneous glassy purple matrix. The chondrocytes tend to be larger, but they're also housed in their sort of small little lacunae. Okay, so one of the benign things that we see in the mandibular bone is the kind of histologic picture of inflammation and necrosis. And so inflammation and necrosis of bone can be due to a number of reasons. That could be true osteomyelitis, meaning acute infection of bone in the setting of sepsis or trauma, et cetera. It could be osteoradionecrosis, secondary to radiation therapy for carcinomas of the head and neck. And it could certainly be related to medications such as bisphosphonates as the most common reason for osteonecrosis related to medicines. So all three of these, whether it be infection, radiation, or medication, have a similar histologic picture of osteonecrosis, acute inflammation, and colonization by oral flora, mostly bacteria. So dead bone manifests as bone without osteocytes in the lacunae. So you can see these holes are essentially empty. You can see that the acute inflammation manifests as neutrophils, and you can see that the bacteria manifest as both small cocci as well as these filamentous actinomyces bacteria. So this is this histologic triad that could be any one of those clinical pictures. Moving into the odontogenic tumors. So we mostly see these coming from periodontists out in the community who are doing bone biopsies or curatages on their patients, but we do now have a physician here who does odontogenic lesions. You sometimes also see these sampled from our head and neck surgeons. So we will talk about the odontogenic lesions briefly. So the most common things we see are cysts that tend to occur around the crown of unerupted molars. Now, this isn't necessarily uniform, but this is a very common setting in which these occur. So you can see the unerupted molar here. You can see this radiolucency kind of around it. The three main types of cysts we see are dentidrous, odontogenic keratocyst, and cystic ameloblastoma. But of course, in order to determine which of those it is, we have to examine the surface epithelium of that cyst. Dentidrous cyst is kind of a nondescript squamous lined cyst with stromal inflammation. This is in contrast to odontogenic keratocyst, which is also squamous, but has a very characteristic morphologic appearance, being 5 to 7 cell layers thin, having this corrugated surface or kind of rugated like cardboard, excuse me. It has a palisaded basal layer, palisaded meaning the cells line up like a picket fence at the bottom here, and it has daughter cysts in the wall, which account for its high rates of recurrence. And so these need to be treated more aggressively with caustic treatment of the cyst wall in order to get rid of these daughter cysts to minimize the risk of recurrence. Dentidrous cysts, not so much. Those can just be curetted and it's done. Sometimes in young patients who have multiple bilateral OKCs, we want to think about specifically Gorlin syndrome, which is OKCs. I believe there's also basal cell carcinomas, medulloblastomas, some other tumors as well. All right, and last but not least, cystic ameloblastoma. So this is sometimes the hardest to diagnose. Usually ameloblastomas are solid. I'll show you a picture of that on the next slide. But for now, the cystic ameloblastomas, the lining of the wall resembles ameloblastic epithelium. And so what does ameloblastic epithelium look like in a more characteristic feature? It has these cells along the edge that are palisading, that are in which the nuclei are oriented away from the basement membrane. That is so-called reverse polarity. So these nuclei pushed up from the basement membrane, so-called reverse polarity, as well as this central, very loose kind of myxoid spindle cell tissue called stellate reticulum. These two features in combination are essentially diagnostic of ameloblastoma. This is the more characteristic solid ameloblastoma, but as I showed you in the prior picture, it could also be extensively cystic. Now, why do I care about this splitting hairs? Well, it has to do with treatment of ameloblastomas. So anything that is cystic, that is confined to the cyst wall or proliferates into the lumen, these can be treated with essentially simple enucleation and curettage, no additional treatment necessary. However, once you start getting daughter cysts in the wall of the ameloblastoma or multiple cysts or solid, these have the tendency for local aggressive growth, locally infiltrative growth, I should say, and require hemimandibulectomy for treatment. So an actual segment of mandible rather than just an enucleation. And so we as pathologists try to put the ameloblastomas in one of these two buckets in order to guide treatment. Moving into the osteosarcomas of jaws. So these are going to be, of course, your prototype malignant bone forming tumor. Three histologic subtypes of osteosarcomas are osteoblastic, making osteoid, chondroblastic, where in addition to osteoid, you also make cartilage, and fibroblastic, where in addition to osteoid, you also make spindle cells. So in order for you to call something an osteosarcoma, it has to have osteoid matrix, but it can also transform or differentiate, I should say, into making cartilage and making fibroblast type cells. Interestingly, most osteosarcomas of the craniofacial bones are clinically different from the osteosarcomas of the long bones. So in the craniofacial bones, they tend to occur in mid-adulthood, so peak sort of 30s, usually are chondroblastic in morphology and do not respond well to chemotherapy regardless of histologic grade. Therefore, primary treatment of craniofacial osteosarcomas is complete resection, if possible with negative margins. Whereas in the long bones, we're dealing mostly with teenagers. Of course, there's a second peak in elderly adults, you know, in relationship to Paget's disease, et cetera, right? But mostly, you know, teenagers, older adults. Usually these are osteoblastic in morphology. Usually they are high grade. And if they are high grade, they are actually highly responsive to chemotherapy. Therefore, these patients, of course, get treated preoperatively with chemotherapy. Unlike the osteosarcomas of the craniofacial bones, which really it's kind of useless in them. Okay, moving into the ear and temporal bone. So there's not too much going on in the ear, at least from a pathologic standpoint, but we do see some of these lesions, so we will talk about them. The normal histology of the middle ear is this very nondescript cuboidal epithelium. The histology of the tympanic membrane is this very thin stratified squamous epithelium with keratin. So on the left, cuboidal, on the right, stratified squamous. Chronic otitis media, we don't normally see histologically because this isn't treated surgically, it's generally treated medically, right? But if you do happen to get a piece of otitis media on your slide, you usually just see, right, itis, inflammation. You sometimes see this excess glandular proliferation of these small glands in the stroma that are not normally found in the middle ear. What we do see as an end-stage manifestation of chronic otitis media is cholesteatoma, because these are surgically treated. So this is a destructive invasion of keratinizing squamous epithelium onto the middle ear, into the eardrum, even into the mastoid bone if it's very aggressive, right? And so while it's not thought that this is necessarily a neoplasm, it's thought to be a very locally destructive process of invasion of this keratin into the delicate components of the ear. The most common neoplasm or tumor of the middle ear is jugulotympanic paraganglioma. As you know, paragangliomas can happen in any, you know, chain ganglia. This is specifically the ganglion of the middle ear. So these should stain positively for neuroendocrine markers being synaptophysin, chromogranin, as pictured on the bottom. They have S100 positive sustentacular cells surrounding these nests, as you may have, you know, remember from medical school, so-called Zellballen, right? Basically just small nests of neuroendocrine cells. These can be locally infiltrative, but usually behave in a benign fashion, i.e. non-metastasizing. Other tumors of the middle ear include adenomas that can range from a generic kind of epithelial adenoma forming glands and trabeculae to a more specific differentiated adenoma that recapitulates the ceruminous or the wax glands, i.e. a ceruminous adenoma. So just keep in mind that these can also occur in the middle ear. Papillary endolymphatic sac tumors are probably the least common, right? Because these are associated with von Hippel-Lindau, which is an uncommon syndrome. But essentially, we see complex branching papillae lined by clear cells. These can be locally destructive into the middle ear, but again, don't really metastasize. So benign, locally destructive, but really non-metastatic. So again, not much in the ear, but there they are. All right, any questions on the inner compartments of the head and neck before we move on to other areas, including the skin?
I wanted to ask if we can see ameloblastomas outside of the jaw.
So great question. You can see a similar tumor in the tibia called an adamantinoma. This is usually on the anterior tibial cortex of sort of younger males, and it is morphologically very, very similar to ameloblastoma. Why it's called adamantinoma in that location, I don't know, but that would be the only other site where it would occur. So ameloblastomas sometimes can originate rather than within the maxilla or the mandibular bone. Sometimes they can originate in the gingiva on top of the bone, but really other than those sites and the tibia, that's pretty much it. You might think about craniopharyngioma as having a similar morphology, but craniopharyngiomas also have some additional histologic features that make them different from ameloblastomas, but there is a tad bit of histologic overlap.
Thank you.
You're welcome. Any other questions? Sorry if my video is lagging today. I don't know what's wrong with it. Okay, so into the skin, squamous, basal, melanoma, Merkel, you know, of course these cancers can happen anywhere, but they often happen in the head and neck because it is a highly sun-exposed area. And we know that skin cancers, you know, have sun as causative etiologies. So we often see these in the head and neck as well as other sun-exposed areas. We're going to talk about a few dermal spindle cell lesions as well. Okay, so starting with squamous cell carcinoma, squames of skin basically look very similar to keratinizing squamous cell carcinomas of mucosal sites. The only reason we know that they originate in skin is because you can see them, right, originating in the skin. Or in the event of we'll talk about this more in the salivary gland section as well, but in the event of a squamous cell carcinoma involving an unexpected site, like a parotid gland, or et cetera, or if you cannot find a primary site, the only thing that differentiates cutaneous from non-cutaneous primaries is the genetic expression of an ultraviolet signature mutational profile. So as I've said, you know, sometimes in tumor boards, squamous cell carcinoma is squamous cell carcinoma is squamous cell carcinoma in a lot of cases. It looks the same in all organs it originates from. It doesn't show any unique genetic mutations, with the exception, right, of squamous cell carcinomas that are related to HPV coming from the oropharynx, related to EBV coming from the nasopharynx, and related to sun exposure coming from the skin with the ultraviolet signature. So those are the three we can differentiate. Other than that, we really can't. Here's a higher power picture of squamous cell carcinoma showing your characteristic keratin pearls, showing cytologic pleomorphism, showing an associated inflammatory neutrophil and eosinophil rich infiltrate. Basal cell carcinoma is our next. It on contrast looks quite blue and has very large kind of rounded nests. There is an attachment to the epithelial surface, which you can see right here. That's characteristic of BCC. It has peripheral palisading as seen in this inset. It often has these white spaces around the nest. This is retraction artifact. This is just an artifact of processing. This is not native to the tumor itself. BCCs tend to be resected surgically and have low risks of metastasis, unlike squames. All right, moving into melanoma. So this is, of course, your malignant tumor of melanocytes. Usually, the primary melanomas are centered on the epithelium and superficial dermis. They start with a melanocytic proliferation within the surface epithelium. And so as you can see here on the bottom left, there are these atypical cells with very clear nuclei and very dark wrinkled, clear cytoplasm and dark wrinkled nuclei. This would be your in situ melanoma. Once it invades beyond the basement membrane of the epithelium, that turns into an invasive melanoma. These tend to be very plump with large nuclei and prominent nucleoli. And again, as we saw in the previous, sometimes you can actually see melanin pigment. Melanoma is graded essentially based on depth of invasion. And so our pathologists use these ocular micrometers to determine depth of invasion. Breslau depth being that from the distance from the granular layer of the epithelium, which you can see right here, to the deepest point of invasion. We don't use this, of course, in an in situ melanoma because you'd only be measuring the component within the epithelium, which doesn't really matter if it's all in situ. This depth only matters if it's invasive. Okay. The other carcinoma of the skin is Merkel cell. So this is our prototypic neuroendocrine carcinoma of the skin. So neuroendocrine carcinomas in all sites have keratin expression, have expression of neuroendocrine markers like synaptophysine chromogranin, and characteristically this dot-like perinuclear staining for CK20, which you can see on the right, so cytokeratin 20. As you know, Merkel can arise anywhere in the skin, you know, the foot, the hand, the head. These commonly metastasize to local regional lymph nodes, so sometimes sentinel node biopsies are done for Merkel. It's thought that Merkel is related to both sun exposure as well as Merkel cell polyoma virus. So sometimes in order to definitively diagnose a Merkel cell, we can look for the presence of that specific virus, which is, you know, a relatively more recent discovery. So I think that's kind of interesting. Okay, moving into the spindle cell lesions of skin. So a very common thing of skin that we see is a fibrous histiocytoma or dermatofibroma. I will say that these don't occur very much on the head and neck. They occur more often on the limbs. They appear as sort of dark raised lesions, dark because the epidermis has some increased pigment in the basal layer, as you can see here. And underneath that epidermis, we have this infiltrative proliferation of very bland spindle cells that dissect through the collagen. Dermatofibromas are essentially benign, not really locally recurring, not even always excised, because clinically they just kind of manifest themselves diagnostically, clinically, without needing a biopsy. However, one spindle cell lesion of the dermis we do see in the head and neck is so-called atypical fibroxanthoma. And so I'm going to say a word of caution about atypical fibroxanthoma because we've seen issues with this diagnosis in general. The issue is, if you look at the cells of a so-called atypical fibroxanthoma, what they are is basically a dermal sarcoma. So these can appear very pleomorphic. They can have numerous mitoses as well as atypical mitoses. They can be epithelioid, they can be spindled. However, if they are restricted to the dermis, they behave in a very indolent fashion, hence the term low grade, right? They can be excised without really much local recurrence, without metastasis. In this specific setting, they do very well. This is generally elderly patients. This is generally sun-exposed skins. This is, again, this pleomorphic neoplasm restricted to the dermis. However, once you get, I don't know if I have a slide on it. No, once you get invasion of this neoplasm below the dermis into the subcutaneous tissue, the behavior changes. So now you have access to all these tissue planes, to lymphatics, to blood vessels, and these behave more as high-grade sarcomas where they recur, they metastasize. And so I would just caution everyone with these dermal malignant spindle cell lesions. I would not diagnose an atypical fibroxanthoma on just a shave biopsy because we don't know what the deep base of it is doing. And we don't know if that depth is invasive into the subcutis or not. If it is, it's a totally different story. All right. So that's my word on AFX versus deeper dermal sarcomas. But both are dermal sarcomas. It's just restricted versus deeper. And behavior, as I said, is very different. We have a few kind of mass-like lesions of the neck. It's 940. All right, so we can get through these. So when we're dealing with masses of the neck, we're sort of separating them into lateral versus midline versus maybe parapharyngeal space in terms of what our most likely diagnoses are. So in the lateral neck, we could be dealing with something like a branchial cleft or lymphoepithelial cyst, certainly like a lymphangioma, especially in a child. In the midline neck, we can be dealing with a thyroglossal duct or a dermoid cyst, both of which are developmental. And then the parapharyngeal space being nerve sheath tumors or salivary tumors. So here's our breakdown of the lateral versus the midline neck. Branchial cleft cysts are essentially developmental remnants from the branchial cleft apparatus that are lined by benign squamous epithelium with lymphoid stroma. Lymphangiomas are lined by lymphatic epithelium, in this case, D240 is an immunomarker that's specific for lymphatic epithelium. So you can see here on the bottom left, they sometimes have little valves in the lumina. Thyroglossal duct cyst in the midline is lined by either squamous or respiratory epithelium, often has thyroid tissue in the wall, so that's helpful for diagnosis. And dermoid, again, your other developmental related cyst, tends to also be lined by keratin, just like the branchial cleft cyst, but does not have necessarily inflammation in the background, and does have skin appendages that feed into the cyst, so hair follicles, sebaceous units, etc. I will make a comment on squamous line cysts of the neck. If we are extremely certain that they are histologically bland and benign, we can call them branchial cleft cysts. However, squamous epithelium in adult patients in the lymph node rich zones of the neck that does not appear bland, that appears atypical or frankly malignant, is essentially metastatic squamous cell carcinoma until proven otherwise, generally coming from the oropharynx. So oropharyngeal HPV-related squamous cell carcinomas can present as cystic neck metastases that clinically, of course, might mimic abscesses, might mimic branchial cleft cysts, but it's really the characteristics of that squamous epithelium that are going to be definitively diagnostic. And so sometimes these can be challenging on FNA or needle biopsy if the epithelium is not well sampled. But in this case, you can see malignant cystic epithelium. We would perform P16 on this to determine if it were positive. If it were positive, that is highly suggestive of oropharynx. Again, if P16 is negative, we could consider something like an EBV to determine if it's coming from the nasopharynx. That is also a possibility. Other than that, site of origin can be difficult to determine if it's P16 and EBV negative. All right, parapharyngeal space. We already mentioned that the two most common lesions of the parapharyngeal space are either salivary gland neoplasms, which we'll talk about in the salivary section, or sort of peripheral nerve sheath or neuroendocrine tumors, those being either schwannomas from Schwann cells or paragangliomas, of course, from your sympathetic chain. So schwannomas are characterized by these kind of hybrid appearances of more paucicellular pale areas and more dark hypercellular areas. Characteristically, the more cellular sections form these structures called verrucae bodies that have palisading nuclei surrounding this central eosinophilic fibrillary core, which you can see here on the left. They have hyalinized blood vessels, but essentially they are benign. You can show S100 positivity because that's what Schwann cells express. This is an example of a schwannoma. We've already seen paragangliomas in the middle ear, but just as a reminder, this of the morphology of paragangliomas of the neck is essentially identical. Small nests or zellballen surrounded by a rich vascular network with cells with granular cytoplasm with salt and pepper characteristic neuroendocrine chromatin. I will mention one thing about paragangliomas, that being we always do immunostain for SDHB in paragangliomas for the following reasons. So unfortunately, the histologic features of paragangliomas are not diagnostic of behavior. So whether they metastasize or not cannot be predicted by H&E morphology alone. The only thing that can be predictive of metastatic or possible metastatic behavior is germline SDH mutation. Specifically, if a patient has a germline SDHB mutation, those have the highest risk of metastasis. Thankfully, germline mutation in any of the SDH genes, A, B, C, D, A, F, can be detected by loss of the SDHB protein by immunohistochemistry. So because this is a complex, they all co-localize together. If one is lost, they are all lost. So SDHB is gone. As you can see on the bottom, you have bottom right, SDHB is retained in the cytoplasm of the sustentacular cells surrounding the nests, but is very, very pale to lost in the actual lesional cells. So this patient should undergo germline screening for SDH mutation. Okay. Additional nodular things we might see in the neck include diseases of lymph nodes, being granulomatous or lymphomatous. So just to remind us, a granuloma is a collection of epithelioid histiocytes, sometimes with giant cells. You can see on the right here, the histiocytes are very pale pink. The giant cells have multiple nuclei, but they are all of histiocyte / macrophage origin. It can have central necrosis, but it does not have to. If it does have central necrosis, that's a little more suggestive of an infection like tuberculosis or fungus. If it does not have necrosis and the granulomas are very small and numerous, you might want to think about sarcoidosis. Here's an example of a very large necrotizing granuloma, which grossly has this very cheesy, cottage cheese-like or so-called caseating necrosis in tuberculosis. You can see on the bottom right are examples of what an AFB stain might look like, which is positive for your little filamentous mycobacteria, or a GMS stain, which is positive for your small yeast forms like actinomyces. Usually you do not see both in the same granuloma. You either see one or the other. In this area of the country, histoplasma is very common. Here are your non-necrotizing granulomas of sarcoidosis. Usually we see this in the lungs and the mediastinal lymph nodes, but once it's in the lung and the mediastinum, it can certainly creep out into the neck. These patients generally are treated, with steroids as an autoimmune disease, but usually as an isolated finding in the head and neck, this is pretty rare. What we can see as isolated findings in the head and neck are certainly lymphomas, right? So we know that lymphomas are solid neoplasms of malignant lymphoid cells within lymph nodes or organs, whereas leukemias are those that are circulating in the blood. So lymphomas are sorted into two large categories, Hodgkin and non-Hodgkin, but I would argue that non-Hodgkin is extremely heterogeneous, and to call something non-Hodgkin lymphoma is essentially meaningless because there are more than 60 types. They range from low grade to high grade. However, with Hodgkin, it's a little more of a homogeneous disease. There are various histologic subtypes. They tend to occur in younger people and then in the mediastinum, whereas non-Hodgkins tend to occur in older people, but as I said, can have varying morphologies and varying behaviors. So classic Hodgkin lymphoma happens in the sort of cervical supraclavicular lymph nodes in many cases, with these two age peaks, as you can see here. The neoplastic cells are these large Reed-Sternberg cells, which are essentially CD30, CD15 positive. These tend to respond well to chemoradiotherapy, and so it's in these young, kids who've had Hodgkin's lymphoma in their mediastinum, often undergo radiation. These can then, as I'm sure you expect, are increased risk for developing other malignancies of the neck, such as thyroid cancers, etc. This is in contrast to the other most common malignant lymphoma of the head and neck, which is diffuse large B-cell lymphoma. So while DLBCL is still more common in our peripheral lymph nodes, it is the most common non-Hodgkin lymphoma in the head and neck of the Waldeyer ring, right? So tonsils, adenoids, base of tongue. So most are sort of unilateral localized disease, so they can resemble, for example, in the tonsil, like an HPV-related carcinoma clinically as a unilateral mass. But there's also, B symptoms, right? Whereas a tonsillar cancer might not have additional B symptoms, they'll probably have a metastasis in the neck. These are monotonous sheets of B cells, which express CD45, which is a generic lymphoid marker, as well as CD20, which is a specific B cell marker. These tend to be more aggressive. They certainly will be treated with chemoradiation. Okay. Then we have our other low-grade lymphomas of the head and neck regions, right? So these are specifically MALT lymphomas, mucosa-associated lymphoid tissue lymphoma. So you can get MALT lymphomas in any mucosal or glandular site of the head and neck, or body, GI tract, for example. So I'm showing you an example here of a salivary malt lymphoma. Usually these are in the background of Sjogren's. You can also have malt lymphomas of the thyroid in the background of Hashimoto's. You can basically see effacement of the glandular tissue by sheets and sheets of lymphoid cells that tend to invade and destroy the epithelium in these so-called lymphoepithelial lesions, as you can see on the bottom right. So whether they be, in the parotid or in the thyroid gland, generally these are resected with high rates of cure. But the risk, of course, is transformation to diffuse large B-cell lymphoma, which we saw on the prior slide. So monitoring these patients for transformation is going to be important. Okay. All right, we're at 9:52, and I don't think we're going to get through salivary, so I think we'll stop here. If you guys have any questions or comments, I'd be happy to take them.
Dr. Cipriani, one of the things that we diagnose the most in neuroradiology are retention cysts in the paranasal sinuses.
Okay.
Have you ever encountered like a cystic appearing tumor in the paranasal sinuses that had been like mislabeled as a simple retention cyst? Is there that risk? Or
Good question. So sorry, not usually. So when you're saying clinically a retention cyst, what I'm picturing histologically is perhaps a very thin, maybe respiratory epithelial lining where the cyst is filled essentially with like mucin, for example. And so when that's clinically the picture, that generally is, I haven't seen like misdiagnoses necessarily, if that's what you're asking. We don't generally see those histologically. I'm not sure how they're treated, if they're sort of suctioned and evacuated and the contents are discarded. But I've never seen personally an example of a misdiagnosis of that.
Great, thank you.
Mm-hmm. Generally, if you're thinking about something like a cystic mucoepidermoid carcinoma or some other cystic neoplasm, my assumption is that generally there'd be some solid component or some other feature that might steer you, radiographically in the right direction.
Okay, makes sense. Thanks.
Yeah. All right. I think our next session is not going to be for another number of months. So I hope you guys have a great holiday. Stay safe. If you guys have any questions or whatever, feel free to email me, and I guess I'll see some of you at Tumor Board.
Thank you.
Yep.
Thanks.
Thank you.